start with the electrocardiogram. This is how we read the electrocardiogram, and going through the normal changes in the heart and up to the ventricular fibrillation and cardiac arrest, and use of the chest compressions and the use of the mechanical CPR. It's just a review of what we have seen in the last classes. So just to remember that electrocardiogram will be the tool that we will use to measure the electrical activity of our heart and the function of the heart. Just to remember, that we will have the polarization in the four chambers of the heart. Remember, we have two atrias and then two ventricles, and those ventricular atrial depolarization and polarization will be represented in our electrocardiogram. Just remember, we have several waves that will show the different phases of the heart function. Remember, we have the P wave, which represents the polarization of the atria, responding to the semiatrial node triggering. The QR complex, the T wave, PR interval, which represent the delay of the auriculoventricular node, and that will allow the filling of the ventricles, and the CT segment, which shows the beginning of the ventricular polarization. It should be flat. Okay. Remember when we talk about the silent rhythm, we said that was the sign, the rhythm that starts in the semiatrial node, which is, as we remember, localized at the right atrium, and that starts with the polarization in the atrial, causing the contraction. Also remember that we must consider the heart rate calculation, because we might consider if it's normal or including the sinus rhythm. And we know that if we are going to measure the atrial rate, we'll be considering the P wave. If we are considering the ventricular rate, it will be measured at the rate of the TRS complex. The heart rate will refer to the number of times that the heart muscle will contract, and this will be averaged in a specific period of time, and we usually use per minute. So we said we will measure the beats per minute. The physiological rate is 60 to 100 beats per minute, and we might obtain the heart rate by counting the large boxes between two R and R interval squares, and then we just divide it between the number of the large squares, 300, and we might get the heart rate. Fourth, we may consider normal heart rate like bradycardia, when this is, will be slower than a normal heart rate, and because the sinus node will send the impulse too slowly, and then the heart rate will be very slow. Bradycardia is considered less than 60 beats per minute. On the other hand, when we talk about tachycardia, we know it's the medical term with the heart rate that goes over 100 beats per minute. So the abnormal electric impulses start in the upper lower chambers and causes that the heart goes faster, beats faster. And we consider tachycardia more than 100 beats per minute. We also must consider and remember that the younger the person is the more the faster the heartbeats. Remember, for babies up to 1 year, it will be 100 to 160 beats per minute. 1 to 10 years, 60 to 144 beats per minute. Over 10 years and adults, we consider 60 to 100 beats per minute. And a condition that is very important to consider is for those athletes, which will have a rate from 40 to 60 beats per minute. As we remember, if we use our electrocardiogram traces, we might find some disturbances in the heart rhythm, which are called abnormal electrical patterns, and we have different kinds of irregular heart rhythms. Just widely, we can consider we have regular or irregular rhythm, and the regular or irregular can be also classified like regularly irregular or irregular, totally irregular. When we talk about those irregular rhythms, we remember when we talk about tachycardia, bradycardia, we have extrasystolic, atrial fibrillation, auricular flutter, or ventricular flutter. And if we talk about those irregular rhythms, just remember we have those that are regularly irregular. It means they have a recurrent pattern of irregularity. They go just like irregular, but still going the same. On the other hand, when we talk about irregular, this is a completely disorganized rhythm. And as an example, we may have the atrial fibrillation. The PR interval will show us the beginning of the P wave and the beginning to the QRS. And we consider if we have the prolongation of this PR interval, we might be diagnosing first degree AT blocks. And if it's too short, then we might diagnose a post-Parkinson white syndrome. Also remember that when we consider the cardiac axis, we must describe the direction of the electrical spread, and which is normally going from 11 o'clock to 5 o'clock. This is the normal one. And as we remember, the lead 2 has the most positive deflection. And if as it is normal, if your rhythm is silent rhythm, then remember this will start in the pacemaker, and the direction of the atrial depolarization will be downward and to the left. Remember that the P wave will be always positive in lead 2 and will be always negative in lead ADR. Also, just to remember that we should consider the ST segmental alteration, which is the line between the end of the QRS complex and the beginning of the T wave. It must be isoelectric, it means it must be flat, and we must be looking for any lower or elevating situation. Like for example, when we are having a patient with a myocardial infarction, those findings are really very specific. The ST segment elevation, it's very significant. Another situation that might affect the rhythm of the heart could be the atrial fibrillation, which it's a condition that will disrupt the heartbeat. If there's any glitch in the heart's electrical system, then it will make the upper chambers, means the arteries, be to beat faster, or they can even shake or fibrillate. Of course, if the atrial rhythm is lost, then it will cause that the lower chambers, means the ventricles, will beat without any syncope. The risk for the atrial fibrillation will be that the blood will be moving very slow, so it may pool inside the heart. And of course, if the blood is standing still, then we have a higher risk for forming blood clots. If those blood clots goes up to the bloodstream in the brain and get stuck, then it may result in stroke. For the ventricular fibrillation, we just must remember that this is a condition where the heartbeat is erratic because the heart is abruptly stopped pumping blood to the body. Eventually, in the ventricular fibrillation, the heart will stop longer from pumping blood to the rest of the body. Of course, this represents a medical emergency because if we did not treat it promptly, this ventricular fibrillation, that it will be a threatening condition and lead to death. Of course, the longer the body is deprived of blood, we might have the greater risk of damage, not only for the brain, but all other the organs of the body. And if we do not take any action fastly, then death can occur in minutes. Just remember, cardiac arrest can also be caused by poisoning. And okay, and just remember that sudden cardiac arrest is the leading cause of death among young athletes. If we talk about ventricular fibrillation, we must consider that a heart must receive a shock using an automatic external defibrillator, so we might reset the electrical system. If we do not perform this reversion, then we may be on the risk of brain death in minutes. So that's what we talk about the cardioversion, which is the medical procedure that will restore the normal heart rate in the people with having a cardiac arrest or having an abnormal heartbeat. This is cardioversion will be done usually sending those electric shocks through some electrodes which we place on our chest. And we can see how after the defibrillation shock, we go back to the sinus breathing. So it's very important if we have a cardiac arrest, we might reverse if we have a cardiopulmonary resuscitation promptly, and we might restore the heart rhythm in a few minutes. Of course, the sooner the signs and symptoms are recognized and treated, we may have a lower risk of morbidity and mortality. And then we had the question, is the heart attack the same as cardiac arrest? Of course, we say it is not. It's not the same because we know the cardiac arrest will occur when the heart functions stop beating unexpectedly. And on the other hand, heart attack will occur when the blood flow to the heart is blocked. Sudden cardiac arrest, we say, is the blood loss of heart function and breathing, and it's associated with the loss of consciousness, spontaneous breathing, and circulation. These patients may or may not have been diagnosed with a heart disease. When we talk about the cardiac arrest, we know that the heart will stop functioning or the function of the heart is arrested or stopped. That's where we get the name for cardiac arrest. The causes for cardiac arrest, as we remember, may be different ones, like arrhythmia, coronary artery disease, cardiomyopathy, long QT syndrome or Brugada syndrome, Marfan syndrome, or common risk factors, which includes chronic diseases. On the other hand, when we talk of the heart attack, we refer to the necrosis or the death of the heart muscle and resulting as a loss of oxygenated blood. We have a block in the artery, and this stops the blood flow to the heart, and eventually it will be resulting in the death of necrosis of this muscle. Most of the time, these symptoms will develop very slowly before the heart attack, and the heart does not usually stop beating completely as it happens in the cardiac arrest. Okay, so it's important for us to remember sudden cardiac arrest is electrical malfunction into the heart stops beating unexpectedly, the victim suddenly is unresponsive, there could be abnormal or maybe not breathing, and they may be the presence of seizure activity. On the other hand, the heart attack will occur when the blood flow is blocked, the section of the heart is not getting the oxygen-rich blood, the victim may remain conscientious or not, but the patient will be symptomatic like on chest or arm or joint pain, or may be having shortness of breath. In both situations, we should call the 911 so we can start giving some life support. And after this, we may start the chain of survival, which is not only used in cardiac arrest, but also in the heart attack. In this situation, we may use the basic life support, and as we remember, this refers to the care that healthcare providers or people that are trained can provide to a person that is under a cardiac or respiratory arrest, or if has an airway obstruction. Remember, this personnel has skills on recognition of signs of sudden cardiac arrest, heart attack, strong coronary body airway, and they have skills of delivering cardiopulmonary resuscitation and the use of defibrillation with automated external defibrillators. They may be acting not only in out of hospital cardiac arrest, but also in hospital cardiac arrest. Just remember that the difference between this situation is that in hospital cardiac arrest, resources are available and different to the out of the hospital cardiac arrest, where the care will depend on the community and the emergency services that will provide the support. And the resources may be or not accessible in the out of the hospital cardiac arrest. And talking about the cardiopulmonary resuscitation, we remember it's offered with the sustained delivery of high quality and effective chest compressions. And if we have the defibrillator available, we'll use it to shock the heart and restore the normal heart rhythm, because it's very, very important to and critical component for the cardiac arrest chain of survival. Okay, the international guideline chest compressions includes, remember, compressions at a depth of 5 to 6 centimeters, a rate of 100 to 120 per minute, allowing the full chest recall between the compressions and with minimum interruptions. As we remember, this is what should be the high quality chest compressions, but we know that when we talk about the out of hospital cardiac arrest, patients will only receive 45% of those recommended international guideline chest compressions. On the other hand, we remember if we do not use the manual compression, we have the option of the mechanical cardiopulmonary resuscitation devices, which will provide those chest compressions with no interruption and uninterrupted and high quality chest compressions. We have two different kinds of mechanical devices, the low distributing band and the piston devices. And as we remember, the low distributing band is offering compressions 80 per minute and a dip of 20% because it goes around the chest of the patient. And on the other hand, the Lucas piston devices will deliver compressions as a rate of 102. Okay. Of course, as we read, with both situations, even manual chest compressions or those mechanical chest compressions, the damage will be exactly the same. And these injuries include fractures from the ribs or sternal or pneumothorax and also visceral organ damage, liver, spleen, and heart. Just remember the trials that we review, they say the risk is the same, totally the same in both situations.